Okay. Right. So the stream should have started now. Let's actually I actually haven't gone over to my YouTube to see if it's live. So sorry, let me go to that first. And let me open up my Facebook so that if there's any questions on Facebook, I can actually read it. Right? And I altered some settings so that the stream is smoother than it usually is. I hope. Okay. Because I'm currently loading like a few things right now. That's why it's like buffered down. But I really hope so. Okay. Yep. Sorry. Am I live right now? It doesn't say in my channel that I'm live. Wow, it really doesn't say I'm live. Okay. Oh, yeah, I am live. Okay, never mind. Right, there we go. Let's see if the shortcuts work. Am I live right now? It doesn't say in my channel that I'm live. There you go, perfect. Oh, let me mute that. Sorry, you're gonna hear two of me in one of those scenes. Okay. How many people are here? Three people are watching. Oh man, well, that boosts my confidence. All right, here we go. But I guess it's being recorded, so people don't actually have to come, and it's not even a long session, you know. Guys, remember, if you have any questions for me, just literally hit me up, and I'll answer them ASAP. Vespimps. Let's go to Vespimps. The thing is loading. It says that my streaming output is green, so which is really good for once. Usually it's red in the other times. That's why it's really laggy. Only Jeremy and Nicola liked it. Well, rest in peace. Okay, so let's just get it started. All right, it's a short session, so let's get it started. So embryology. For those who are watching, for those who will watch, embryology, I can say without a doubt, is gonna be a very high yield in your exam. Okay, I shouldn't have said that. For us, we thought that they were gonna test everything else about the head and neck. Everyone kept saying that they're gonna test the eyes, so we memorized all the 10 layers of the retina and the cornea and stuff. But then we go into the exam and like we have 12, 13 questions on embryology alone. And I'm not even kidding. That legitimately did happen, right? And we forgot that Lazarus is on board. And Lazarus is an anatomy fiend. Well, not anatomy, embryology fiend. She loves that shite. So, this was the thing that she kept stressing to us. Okay? So let's just get it started on what she'll ask. So I hope the concept of the embryology of the head and neck is clear to you. A common point of confusion also is with this embryological, the embryology of the head and neck with the pharyngeal arches, clefts, and pouches, is that it's not like similar to the thing before that I explained. So similar to the ciliary muscle. This is like a little U-shaped thing. Okay, it's not like two little things. It's called an arch because it arches towards the screen and then back away from the screen to connect with this one. Okay, it arches all back and forth, and I really hope you know what the arches are and what is the clefts and what is the pouches. Okay, so if you don't know, the outside are the clefts and the insides are the pouches. Okay. And what's also important for you to know in this is a few things. One is the fact that what forms each of these. Guys, I'm telling you now, this was examined like crazy. Okay, so the point I've highlighted is important because she did ask us in the lecture, and it could very well easily be an exam question. So, neural crest tissues. I wrote issues. Tissues results in head and neck, GIT, and heart. Okay, so what that means is that if you see a patient with head and neck, GIT, and heart issues, they'll probably have some neural crest deficiency or neural crest defect. Sorry. Right. So this diagram, what I'm trying to show is that you see how the mesoderm, or the blue part, or basically the pharyngeal cleft after the first one, it actually all invaginates down and covers all the other pharyngeal clefts. So you see how this exists here, one like second, third, and fourth pharyngeal cleft. It actually invaginates down and covers it all, and all you're left with is like a cervical sinus. Okay, that is important to know, because what they'll say is which of these pharyngeal clefts it does not invaginate or something, and it will be 1, 2, 3, 4, 5, and obviously it's 1 because that's the only one remaining. Okay. Another thing they asked us was which of these combination of cleft and pouch forms the auditory tube, and it's number 1. But they also said which of these is also what is it also innervated by. So obviously it's cranial nerve 8 because it's auditory tube, right? Similarly, just remember also the pharyngeal pouches over here and here as well. So a very, very common thing that I'm sure you've heard before is the parathyroid gland. Okay, so the common point of confusion is that the parathyroid gland, superior and inferior. Superior is third, inferior fourth. No, incorrect. So what happens is that when the third descends down, it kind of, imagine, drags down the fourth with it. So this drops down, and then like it goes past the fourth, and then it drags the fourth down. So the third is actually the inferior, and the fourth is actually the superior. Okay, it's the other way around. Just be careful of it. Okay. Also keep in mind the thymus, like the red part over here. That people don't actually look at that, and this was an exam question for us. So the thymus is the result of the third. Okay, the third pharyngeal pouch, right? Honestly, like everything is important. The palatine tussles too. Like this diagram, you just need to know off the back of your hand. This diagram, I'm so thankful for my notes because I paid attention to embryology. A lot of people didn't, and so they actually lost out a lot of marks for embryology, whereas, I may not have. So this diagram is what she used to make questions. So literally, so obviously you should know that arch 1 is cranial nerve 5. You should know that, and it also does muscles of mastication. Right, and it also does the mylohyoid anterior. Like the red thing that I'm highlighting here, you need to know that by heart. That was an exam question. Which of these muscles are not done by cranial nerve 7? And it gave us like mylohyoid, right? So you need to know that by heart. You also need to know the bones by heart. Okay, so the 3 bones of the ear is the malleus, the incus, and the stapes. Okay, but all you need to know is that the stapes is the only ear bone that is not done by pharyngeal arch 1. It is done by pharyngeal arch 2. So look at this diagram. See how stapes is not there? Yeah, stapes is pharyngeal arch 2. And think about the location of the styloid and the stapes, and the styloid is also arch 2. This was our exam question. These two, both of them, was literally which of these bones in the ear is not for arch, which of these is arch 2, and it gave us like these two and a muscle, and it was stapes. And then it said which of these pharyngeal arches is the styloid process belong to, and obviously it's arch 2, right? Also note the split between the hyoid bone. One of the questions they also asked us, holy crap, they asked so much the embryology question, was which 2 arches forms the hyoid bone, right? And it's 2 and 3, with the lesser horn being in 2 and the greater horn being in 3. Okay, they also they can easily ask which of these is formed by the thyroid cartilage, which of the arches form thyroid cartilage. So it's 4 and 6, right? And which of the remember it's 4 and 6 and not 4 and 5. That's an easy point of confusion. And cricoid cartilage is 6 as well. Okay, you just need to know this diagram and this diagram. You just need to know off by heart. Okay, arch 2. So stapes, all the muscles. Once again, you need to know all the muscles and the nerve as well. They love asking the nerves as well. So it goes in order. So 5, 7, 9, and then and then it doesn't. And then kind of not goes in order. So it's 10, not 11. Okay, so 5, 7, 9, 10. Right. No arch 5 because we don't have gills. And you do also need to know the split of laryngeal nerves for arch 4 and arch 6. So superior laryngeal for 4, recurrent laryngeal for 6. Okay, you'll get more into that once you start the neck and the kind of ENT really, which is week 4. So not this week. And rest in peace you, because that's like the exam week. Okay, so this is also pretty important. They also like testing this stuff and this diagram here. So pouch and cleft 1, like honestly these are all rote learning. There's no way I can easily explain this to you, but I'm just telling you which one's more examinable. And honestly, all of this part especially inferior thymus. I've already touched on this before about the thymus and the inferior parathyroid. About how pouch 2 also, I think, which one was it, I forget, but one the no, I forget, don't worry about it. Ultimate branchial bodies, they also forget about this as well. The parafollicular cells, just know that everything here is examinable. Now, DiGeorge syndrome, it kind of makes sense because it's the abnormality of pharyngeal arches. So if pouch 3 doesn't differentiate, they don't have a thymus. 3 and 4 doesn't differentiate, they don't even have a thyroid, hypothyroidism, okay? Arch 1 defect, you don't have your mouth has a defect because it doesn't join properly. And once again, a buzzword for neurocrestals, if you have a defect in neurocrestal, you have cardiac abnormalities because your neurocrestal does GI, head and neck, and cardiac. Tongue development, this actually wasn't tested as much for us, so this may as well be tested for you guys, so just be careful. But it basically covers the innervation of the tongue and what does what, okay? So the part that I think we had to remember was that where it arises from, I think, was where we had to do it. Like which embryological remnant that it comes from. So I think it's like the thyroglossal duct or something like that, right? If I were to go back, yeah, so this is the part I was trying to kind of talk about last time, like 5 minutes ago. So arch 2, the quarter tympani, right? Basically, they have no kind of innervation. They have no kind of they really don't have anything to do with the face, the facial nerve really, except for the nervous contribution. Obviously, except for the muscles, right? Except for the muscles, for sensation-wise, all they left is just the nervous contribution. That's really it, right? Because if you look at this diagram, 1, 2, 3, the tongue is formed by all four, the 1, 2, 3, and 4, right? But then as you form the tongue, the pharyngeal arch 3 disappears, and all you're left with is 4, 2, and 1, and all you're left with the remnant of the third one is just the nervous innervation, okay? And also never forget the fact that the vagus nerve is a part of the tongue all the way posteriorly. Also remember the fact that the olfactory nerve, so CN1, also does slight tasting, like very, very slight tasting. So I think the exam question that we got was which of these nerves has no impact in tasting, and a lot of people were confused by olfactory nerve, and then they had like one BS nerve, like I think cranial nerve 10, I don't know, not 10, sorry, like cranial nerve 12 or something, and they were like, wait, cranial nerve 1, wait, that's smell, but then it's apparently, not apparently, like it's a fact, cranial nerve 1 actually does have some taste properties. So I thought this was going to be important because they kept talking about it. The only important part that they came up in our exam was the foramen cecum that grows into the thyroid, really, right? Yeah, I don't know. Like I remember the ankylosing because they talked about it, but nothing too important. I think the important part of this one is that foramen cecum is the posterior third of the tongue and it goes down to form the thyroid, okay? And another thing important that she talked about, I think, do I have a picture here? No, I don't. Okay, so it can get caught, right? It can get caught and basically form a thyroglossal cyst, right? Which is like a midline swelling or something. Yeah, midline swelling along pharynx. There you go. Okay, and it's the thyroglossal duct remains as a pyramidal lobe in the thyroid. So the one you've seen in the picture. Do I have a picture for the pyramidal thyroid? No, I don't. Okay, never mind. So it's basically like a superior pyramidal shape. Okay, and it's just swelling around the pharynx. I hated this. I really hated this. I thought that her lecture explained it kind of well. Like, you know, I'm really trying to say kind of well. The philtrum is okay. You do need to know that the medial nasal prominence, the medial nasal prominence is the one that forms the philtrum. Okay, that's something that can be examined pretty easily. Know that the majority of the face over here is formed by the maxillary prominence, and only the nostrils are basically formed by the is formed by the lateral nasal prominence. And the conjoining, like a space between those two, is the nasolacrimal groove, and the space between is the philtrum. Okay. Any questions? No. All right. Cool. I can keep going. What else? Okay, so these clinical findings definitely can be tested. So micrognathia is basically the inability to form a chin. So this is what Leafy has. Okay, so it's an undeveloped mandibular process, and as the picture suggests, there you go. Very easy to spot. Basically, because your mandibular swellings don't grow enough, and a clefted chin or a butt chin, even though it may look good on certain people, like Superman over here, it's basically just not a non-convergence of the mandibular swellings. And obviously, fetal alcohol syndrome is your prominences don't grow properly, and you have it's a characteristic fetal alcohol syndrome look. Okay, the hard palate. The hard palate, basically, what you need to know is that the front four teeth is basically not done by the maxillary process. Okay, it's done by the medial nasal process, the same thing that does the philtron. So this part here. Okay, medial nasal prominence. Okay, so medial nasal prominence sends the hard palate down in the first four superior teeth. Maxillary process sends this shelf over here, and then like the fusion of the shelves is the midline over here. Okay, right? Now, cleft palate occurs when there's kind of like a gap between the two shelves, or between the hard palate of the medial nasal prominence and the maxillary prominence, etc. So I'll show you here. So this one is between the two, this one's between the shelves, and this one's both, right? So it can happen to all of them. Now the tongue formation, basically, I'm not sure if she explained it well enough, but so the mandibular processes, or the two shelves, right? The two palatine shelves, okay, they need to grow to allow the tongue to migrate down. Okay, so I'm not sure if I've got a good picture of it before. No, this is literally the only picture I added. I have another good picture. Damn it. So basically, the tongue occludes the two shelves meeting. Okay, so it needs to do a simultaneous process of the maxillary processes expanding to allow the tongue enough space to go down, and so that when it goes down, these two shelves can meet. If it doesn't happen, this occurs. So basically, cleft palate. Alright, next one, week 3, temporal or infratemporal fossa. You'd be surprised as to how low yield this is. And even now, we make kind of memes and jokes about this kind of stuff. And I think it may be because it's before your exam, like 1 week, like literally right before your exam, so they think it's a bit too unfair to test it. I don't believe that. I think they're heartless mother effers. So that thing is very, very fair game for them to be able to test it. Okay, is my stream still going well? I hope so. Yeah. Let me close that. Let me pause that. My CPU is kind of like whirring away. Okay, awesome. All right, infratemporal fossa. So the infratemporal fossa is this space over here. Okay, it's the space that's near the maxilla mandible, and that's below the actual temporal bone itself. Okay, so I don't think you need to know the roof and the floor, but it is worth knowing anyway. So it's basically between the it's between the pterion itself, so this space over here, right? And the lateral is the temporalis fascia, so the fascia of the actual muscle itself. So this space all the way here is the temporal fossa. Sorry, this is the temporal fossa. This is the infratemporal fossa. Right, that's what I meant. The infratemporal fossa is the more important one. I don't even know why I talked about the temporal fossa. I think it was an exam. I think it was an anatomy workbook question. But yeah, right. This is the more important one. Sorry. The lateral kind of border for this is the ramus of the mandible. So the mandible's been removed, but you can imagine if you on your own face, you can feel it. Is your jaw itself is the lateral. Okay, the medial is the lateral pterygoid plate of the sphenoid. So it's literally this over here. So it's between the jawbone and this over here. Okay. Now, over the anterior and posterior is just a maxilla as well as the styloid process. So this little styloid process here and the maxilla. Easy to visualize in the diagrams like this. Okay. Now, they have basically the muscles of mastication. This is when I actually learn about the muscle of mastication. The pterygoid venous, the mandibular nerve, the otic ganglion, and maxillary artery. I think those 3 are the more important ones. And if you recall previously, as like revision, the otic ganglion is what the auriculotemporal nerve of the previous nerve supplies parasympathetic innervation to the parotid gland. But we'll talk about that soon, okay? We'll talk about that soon. And if you want to question to yourself, what innervates the parotid gland parasympathetically? Dun, 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 dun. So specific osteology. So the temporomandibular joint is basically the joint between the temporal bone and the mandible, right? It doesn't take too much explaining. And basically, there's a lot of things that can go wrong with it, which I'm hopefully going to mention in the clinical session, okay? Even though the ligaments were mentioned as part of the anatomy workbook, I don't think it's too important to know. The only thing you do need to know is the lateral ligament, basically, with the postcolonal tubercle, prevents posterior dislocation. So what prevents posterior dislocation? It's the lateral ligament, okay? So sphenomandibular ligament from spino to lingula. No, you don't need to know this important one. You need to know this for like anatomy tutorials, but not for the exam, I don't think. Right, so specific osteology of the actual mandible. Now we should have covered this previously, but all these highlighted ones are important. So the condylar process, the coronoid process, which are not confusing at all. Lingula, that's in front of the mandibular foramen, that allows for the inferior alveolar nerve. Inferior alveolar nerve, I think that's the right name. Mylohyoid groove, mental protuberance for when the mental nerve comes out. Okay. Right. Inferior alveolar, there you go. It is right. Parotid gland, I think this is the more important one. So parotid gland is basically the 100% serous. So this is apparently a buzzword. It's never come up for us, but this is apparently a buzzword, so that the parotid gland is 100% serous, right? And obviously it contains, and this is also another exam questionable stuff. So what does the parotid gland contain? It contains the facial nerve, the retromandibular vein, and the external carotid artery. Okay, really important to know. We did this for a practice exam, and it didn't come up. So that for us, so that's fantastic. Okay, this is also important, but this is going to come up in like week 5 stuff, but it's enveloped by investing fascia. Just remember this because it will come up later on in your weeks. So parotid gland, so this is when we start talking about the actual otic ganglion, I think, which is even though I mentioned the first week, the first live stream, this is finally I'm getting more in depth with it. So the parotid gland is innervated by the cranial nerve 9, the glossopharyngeal, okay? So the glossopharyngeal nerve gives rise to the tympanic nerve, right? So the tympanic nerve goes into the ear, obviously, tympanic, and forms tympanic plexus on a part of the ear, which you don't need to know yet, but you will learn later. Come back to this part after you learn about the ear, and then it will make sense more. So tympanic plexus gives off lesser petrosal, which, as you already know, or hopefully know, it kind of descends down a foramen ovale into the infratemporal fossa, okay? And it synapses to form the otic ganglion with the deep, and then remember the deep petrosal as well? Yeah. So the parasympathetic fibers go with the auriculotemporal nerve from the mandibular nerve of cranial nerve V3 to innervate the parotid gland, okay? So, wait a minute. Wait a minute. I think I have made an error here. No, I'm right. Yeah, so 9 and 3. 9 and 5. Hold on, let me get something. Wait, someone asked a question. Will you? No, yes, I was thinking about streaming the exam special. Yeah, no. Because I have a Kieran's birthday party tonight, so that's gonna be pretty cool. Whoop whoop. But yeah, I was gonna definitely talk I'm not sure how I'm gonna run it. I might do like a kind of online Socrative, and you guys just, as usual, you come in and do whatever you want. I don't know. Hopefully, I hope so. Who am I gonna vote for? Why are you asking me this on the stream? Right. So, right. Sorry. Let's get back into the stream. Right, so the glossopharyngeal nerve provides pre-synaptic parasympathetic innervation to the parotid gland, and post-synaptic is through the auriculotemporal. So 5 and 9 provide the parasympathetic. The skin over, yeah, dude, that's not as important, okay? Right, maxillary nerve branches. I think that you need to know this. Like, not all the branches. Like, look at this diagram. It's a mess. Okay, you need to know only a few. So the middle meningeal, the infraorbital, and supraalveolar. Supraalveolar, I mentioned beforehand, is the dentistry one, and infraorbital is the one that goes below the eye. Okay. And the branches of the mandibular nerve. I don't know why I tried to remember this. However, a lot of these nerves actually ended up being kind of important, so I ended up learning it anyway. Right. So inferior alveolar nerve, um, obviously is the one that is dentistry related. Masseteric is the one that supplies the masseters. Medial pterygoid nerve, obviously the medial pterygoid. Deep temporal nerve is for the temporalis. Like, look at the names; they're fucking perfect, right? Buccal nerve is sensory. Don't get confused with the buccal branch, which is motor. Okay, just keep in mind. Auricular temporal is just the middle meningeal and also provides parasympathetic postsynaptically to the parotid gland. The lateral pterygoid, motor, and the lingual. And the lingual, oh, you should obviously know by now that it provides the general sensation of the anterior two-thirds of the tongue. Okay? Okay. The maxillary artery and veins, I don't think it's too important, but if you want to learn it, you can. Muscles of mastication, this is fantastic. You do need to know these. You really do need to know this because some of the at least one question will be on this, right? So know that the lateral pterygoid is the main one for protrusion. So protrusion meaning like if you stuck out your jaw, like like really stuck out your jaw, that's the main muscles for protrusion. I'm not sure how that sound was meant to signify protrusion, but we get each other. We get each other, right? Also know which muscles connect to where, because not all of them connect simply on the angle of mandible. It's kind of like varied slightly. So like for example, the how lateral pterygoid attaches to the condyle of the mandible, whereas medial pterygoid has the angle of the mandible. Right? It's something you need to know. Yeah, and depression of opening the mouth is usually gravity actually, and muscles are only used when depressing your mouth against against resistance, right? So these are not as important. So just remember lateral pterygoid. So clicking, lockjaw, and deviated jaw. This was in your anatomy workbook and is the clinical conditions that people have, and it's actually pretty common. Okay, so I have clicking jaw. Pretty common. Some people have severe TMJ, so which is not kind of sad. So clicking jaw basically occurs because there's crepitus, because there's a delay in the condyle moving along with your jaw. So look at your jaw, just your jaw closed, jaw open. But then when you close your jaw, okay, it goes in there, but there's just slight. Sorry, this is normal. There's a slight delay. Sorry, I don't know why I keep pointing at the wrong images. There's a slight delay of the condyle joining in, and so it causes a little click. Right? I have it. It's kind of annoying. Kind of annoying. Yeah, definitely annoying. Lockjaw is the more kind of not pathological, but the more important one, where yawning or taking a large bite, you completely contract the lateral pterygoid muscle, okay, and your mandible dislocates anteriorly, okay. So your mandible dislocates anteriorly, and yeah. So if you don't, sorry, I should kind of orientate yourself to this. So this circle here is anterior, this is posterior, okay? So when you open the jaw, when you close your jaw, it goes in, but the condyle is delayed, okay? It's cool. So in this one, basically what happens is that your mandible gets dislocated anteriorly because of your pterygoid muscle, lateral pterygoid specifically. And so your mandible gets depressed and your condyle is completely stuck, okay? Your cartilage is stuck, right? And it can also, and you can't really move it that much, and you could also, it can occur because if you get like punched on the side as well. Posterior dislocation is not too uncommon because once again the lateral ligament that I mentioned beforehand is the one that keeps it away from posterior dislocation. Deviated jaw is basically the clinical signal. So this is another exam question. So all these, okay, these are really examinable stuff. So deviation of certain muscles are super examinable. Right, so this is the one you need to know. So when you open your mouth and your left jaw if it deviates to the left, which lesion is it? Okay, and ignore the fact that I wrote towards the lesion because if it deviates to the left, something's wrong with the left nerve. Okay, right. So how do I even explain this? Okay, it deviates towards his lesion. Yeah, okay. So basically, because when you try to open your mouth, right, the lesion, the one with the side with the lesion, their muscles don't work. So when you open it, the muscles that do work, it kind of opens, but it's similar to the lung in the fact that when it opens, since the other side isn't opening normally, it kind of moves to that side because it's just not working, right? And so it deviates towards the lesion. And I'll explain this more when we talk about the deviations later on. Pterion pressure, once again, you should obviously know this. Middle artery below the pterion causes an extradural or epidural hematoma. Temporal or giant cell arteritis. Temporal giant cell arteritis is basically the inflammation of blood vessels. So arteritis, so inflammation of the arteries, is specifically the superficial temporal artery. Buzzword as hell. Superficial temporal artery. Okay. So basically, the signs and symptoms include tinnitus, so you start like hearing weird stuff. Tender scalp, so when you like brush your hair, it kind of hurts. Tinnitus, so you can't hear very well. And polymyalgia rheumatica, or basically your muscles are all sore. Okay, polymyalgia, multiple muscles, rheumatica, kind of rheumatoid soreness. Okay, so superficial temporal artery, temporal giant arteritis. You get tinnitus, muscle soreness, tender scalp. Okay. And the reason that this is an emergency is because in severe cases, this can kind of occlude the ophthalmic artery, and as you know, of the internal carotid, and as you know, this can cause vision loss. So you need to take care of that. Mumps, although uncommon, is the painful swelling of your parotid glands. Okay, and this can also cause parotitis, which is simply the inflammation of the parotid gland. And because facial nerves in between the parotid gland, inflammation of parotid gland or parotitis can cause facial paralysis. Inferior alveolar nerve block, as I mentioned beforehand, they inject it, doesn't work. You kind of numbs your chin and lower lip. If you get it wrong, you can screw up your cranial nerve 7. Okay? Right. There you go. Nothing too much, nothing too important. Just some yield stuff. Okay? So thanks for coming, everybody. I'm glad these are so useful and everyone's so excited to watch them. I should make them one-time things so that people have to watch, right? I should do that just to be an asshole. Alright, laters, guys.